Welcome back to Child Mental Health for Pediatric Clinicians, helping you help kids. I'm your host, Dr. Elise Fallucco, child psychiatrist and mom. Today, we're continuing our discussion with the illustrious Dr. Jeffrey Strawn, child psychiatrist and co-author of the new book, Stahl's D-Prescriber's Guide, which addresses the really important issue of what is the best way to come off of medicines or to switch from one medicine to another. In today's episode, we're focusing on the tricky issue of how do you switch between SSRI medications. So without further ado, let's get back to the conversation. Dr. Strawn, I often get asked about what is the best way to switch from one SSRI medication to another. Prior to the release of your book, we didn't have a lot of evidence-based guidance to tell us how could we safely transition patients from one medication to another. So let's start with the clinical case. Let's say we've got a child who we've started on one SSRI for anxiety and titrated up to an appropriate dose, but there's no major improvement, and we're thinking about switching to a different SSRI. In your book, you talk about 3 different approaches to switching medications. Can you walk us through those 3 different strategies and tell us what is the best way to do it?
And I think setting that up in the way that you did is really important, because when we think about this situation where somebody has not responded, they've not gotten really to remission from an SSRI, there's actually good evidence that switching to another SSRI in anxiety disorders and in depression may produce benefit. Now, in terms of that switching over, there are probably hundreds of ways that people have done this, either intentionally or unintentionally. So thinking about this approach, maybe just to go through a couple of these, one would be the direct stop. So, for example, I have a patient treated with sertraline, and I am switching to fluoxetine. And I stop my first antidepressant and then start my second antidepressant. That can be helpful in some situations, perhaps when I'm having a side effect with one medication, for example, the first SSRI. But the issue is that oftentimes, just in switching over directly, I'm at a point now where I no longer have antidepressant 1 in my system, but I don't yet have antidepressant 2 fully on board, especially depending on the pharmacokinetics of the second antidepressant. And so that leaves me potentially a bit behind the 8 ball if I now realize, oh, antidepressant 1 was actually doing more than I thought it was doing. Now, similar to that is the taper, then the switch. So you imagine, rather than just switching directly from antidepressant 1 to antidepressant 2, I'm going to taper antidepressant 1 and then slowly titrate antidepressant 2. Same issue as we just described in terms of that first switching strategy.
I think historically, those 2 types that you described were the most common ways that I've seen people try to go from antidepressant number 1 to antidepressant number 2 in practice. So
I agree. That's what I see as well.
Yeah. The taper and switch, taper antidepressant 1 and then switch and start antidepressant 2 and gradually titrate it up, always to me felt incredibly slow. And I think the reality is, as you described so well, that the patient is going for weeks, if not months, essentially untreated or inadequately treated with a relatively low blood level of any type of antidepressant in that case. And so while I think it feels like a more conservative approach, I've always shied away from that. And I am much more of a fan of the direct stop, stop antidepressant number 1 and start antidepressant number 2. What I have taught pediatricians, but I'm going to have to update it after you and I talk, is that I would usually stop antidepressant number 1 and then start antidepressant number 2, not at the lowest possible dose, but at a sort of pharmacologically equivalent dose, slightly lower than whatever the pharmacologic equivalent would be, which still runs you into the problem of it's going to still take 4 to 6 weeks for antidepressant number 2 to work, and antidepressant number 1 is gone.
Right. And I think the other issue is, when we're talking about starting at a higher or lower dose of the second antidepressant, one of the issues is that starting dose doesn't predict absorption or time to steady state. And so, unfortunately, those are immovable from a pharmacologic standpoint, other than just, quite frankly, through the use of time. No way that I'm aware of really with an orally administered medication to get us to steady state faster. Now, again, as much as I'm emphasizing steady state, I do want to probably also make sure that people are pretty clear that steady state does not equal efficacy, and efficacy does not mean steady state, but it is still a very, very important pharmacologic principle.
So your point is well taken, that regardless of what dose you start at, it's still going to take the same amount of time to reach steady state and to be able to tell whether we're seeing a response in our patients. Okay, so we talked about two of the ways to switch SSRIs. You either do the direct stop and start or the taper and then switch. You were about to tell us about the third way to switch SSRIs.
That's right. I was moving on to the third way, which is probably what I do a bit more of recently, which is the cross-titration. So in some form, I'm potentially beginning to decrease antidepressant 1 as I'm starting antidepressant 2. But here's where it gets just a little complicated. Not too complicated, but just a little bit more complicated. So this is where I really need to consider the individual antidepressants. So for example, if I'm looking at a short half-life antidepressant as being antidepressant 1, and antidepressant 2 is also a short half-life antidepressant, that titration strategy or cross-titration strategy is going to be different than, say, for example, if I'm going from or to fluoxetine, which of course your savvy listeners know is a very, very long half-life medication with a half-life of fluoxetine probably somewhere around 7 days and a half-life of its active metabolite, norfluoxetine, being around 14 days.
So you're saying the cross-titration approach is start antidepressant 2 while continuing antidepressant 1 with the plan of gradually decreasing the dose of antidepressant 1 while titrating up on antidepressant 2, which means you're on two meds at the same time, which I have to tell you, a lot of pediatric clinicians fear, in part because of the theoretical risk of serotonin syndrome. Let's work through clinical cases so we can talk about, the practical implications of going from short half-life to long half-life and vice versa and sort of work through that. Let's say we have a teenager on sertraline, say 150 milligrams for anxiety. It has been really well tolerated, but for whatever reason, after a solid trial, the clinician is saying, I don't think this is really getting us where we need to be. We're not seeing any increased benefit as we continue to titrate up. We need to try a different SSRI. This is the only SSRI that the patient has tried. So let's say the choice is to switch to fluoxetine, which, as you mentioned, has the very long half-life, especially relative to sertraline. So 150 milligrams to sertraline to a new trial of fluoxetine. How do you approach it?
So here we're going from, as you pointed out, short half-life SSRI to long half-life SSRI. So the issue here is that fluoxetine is actually going to take quite a bit of time to actually get into the system. Here again, steady state does not equal efficacy. Efficacy does not equal steady state, but still very important pharmacologically. So in this situation, what I would do, as you mentioned, in the absence of side effects, is to start the fluoxetine while I still have the patient on that treatment dose of sertraline, so 150 milligrams. And then I would slowly increase the dose of fluoxetine over several weeks as I'm maintaining the dose of the sertraline. After I'm at 20 or 30 milligrams of fluoxetine, that is the point when I would actually begin to decrease the dose of the sertraline. However, you mentioned the serotonin syndrome, and I'm going to expand that in terms of just serotonergic side effects. So if I am running into side effects, for example, nausea, vomiting, diarrhea, flushing, increased motor tension, as well as perhaps some restlessness that's not attributable to the underlying anxiety or to psychomotor agitation associated with depression, that's where I would perhaps start decreasing that dose of sertraline a bit faster. Most of the time, in terms of these serotonergic side effects, we'll see something much milder than what we would typically see with a serotonin syndrome.
That's a really good point. When you're making the choice to have two SSRIs on board during this process of cross titration, you'd look out for GI side effects like nausea, vomiting, diarrhea, as well as flushing, restlessness, and make sure that these symptoms are not due to underlying exacerbation or underlying anxiety, depression, other stressors.
Exactly.
So we're continuing sertraline 150 milligrams for a while, really, until we feel comfortable that we have increased up to about 20 or 30 milligrams of fluoxetine. 2 to 3 weeks, you said? I assume you're starting at 10 milligrams.
I did, in my mind, envision starting at 10 milligrams. I guess I should have asked a little bit more about the hypothetical patient.
So this is a teenager with pretty poorly controlled anxiety, had not developed side effects to medication previously, no symptoms of depression, some somatic symptoms of anxiety as well, kind of chronic headaches, occasional stomach aches, but functioning pretty well in school and even in extracurriculars, but just having more psychological distress.
And so in this situation, I would probably still start at 10 milligrams and then would go to 20. And I know some people do go from 20 to 40. I tend to take a pit stop at 30 before going all the way up to 40 milligrams.
I feel like what I've been telling my pediatric clinicians has been wrong in not starting at the typical starting dose, but just jumping up to a higher dose. Is there any case in which you would go ahead and start at 20 of fluoxetine? I do hear your point about, it takes 5 half-lives to reach steady state. And steady state is not the same thing as efficacy. So if we start at 10 or if we start at 20, it's still going to take us the same amount of time to get to steady state.
Absolutely. And I think that's such an important point because I've heard clinicians say, oh, I start at a higher dose, so I get to steady state faster. That is not true. That doesn't happen. It gets to a peak concentration faster, or you get a higher peak concentration, I should say. But really, all that does is produce side effects, unfortunately.
I think this is a good time to remind our listeners that just because we had titrated up to a fairly high dose of sertraline and found that it didn't work or was only partially effective, that doesn't necessarily predict that the patient's going to need a similarly high dose of a different SSRI.
That is absolutely correct.
I like that you're only taking 2 to 3 weeks to get up to probably a therapeutic dose for anxiety, either 20 or 30 milligrams of the fluoxetine. And then once you're at that dose, then you would start decreasing the sertraline. Talk us through how you would decrease it and what's your timing to go from 150 milligrams to 0.
So once I'm at the fluoxetine, and again, if the patient is having side effects, that affects how quickly I would taper off. But let's say that the patient is actually doing great now that they're on 30 milligrams of fluoxetine. At that point, I would actually taper the sertraline off relatively quickly, probably over several weeks.
The way that I've approached tapering off over the course of several weeks is 150 milligrams down to, let's say, 100 for a week, down to 50 for another week. If we're okay, either stop at that point or can go down to 25. Do you have a different approach?
That is exactly what I would do.
Okay.
And I like how you almost added an asterisk to the 25.
Just to be extra conservative, because you never know.
I think the other piece too is in terms of when we're thinking about the receptor pharmacology of these different antidepressants, that's something that may also inform this cross titration. This is less of an issue when we're talking about the antidepressants, but when we're talking about some other medications where we have, say, an antidepressant that has a lot of antihistaminergic effects, or a lot of anticholinergic effects. We don't use paroxetine much anymore, although that would be the classic one in terms of these receptor profiles. But in that situation, again, just thinking about the receptor pharmacology, it helps us predict what we're going to see. So as I decrease the dose of paroxetine, so Paxil, and I lose that antihistamine effect, I lose that anticholinergic effect, I may start to see rebound symptoms of that. One of the other issues that's really important for clinicians to distinguish, and I've run into this recently, just a couple of weeks ago in my own clinic, is that as I'm tapering from one antidepressant or one medication to another medication, it's really important that we try to distinguish what might be an effect of stopping the first medication versus a side effect of the new medication. Because often what I find is that as a clinician, I'm likely to attribute it to the new medication. And that's the same in terms of patients, and it's also the same in terms of their families. I recently ran into this with a patient that was switching from atomoxetine to Luvox or fluvoxamine. Now, this is a patient who was also treated with a stimulant for ADHD. And what happened was some of his ADHD symptoms, in fact, got a little bit worse. And the family and the patient initially attributed that to the fluvoxamine, when in reality, it was the coming off of the atomoxetine or Strattera.
There was a reason you were coming off of the atomoxetine. I'm imagining it was due to perceived lack of efficacy, or was there another reason?
Lack of efficacy, and it really wasn't doing anything in terms of touching the anxiety. So this is where, again, we need to be the pharmacological or psychiatric detective as we're trying to figure out to what medication to attribute a side effect or a change in efficacy.
And so you're thinking atomoxetine's not helping anxiety. It's really not doing much for the ADHD. So you're coming off of that, starting a new medication for anxiety. But as the ADHD gets worse, everybody thinks, oh, it's the new medication because that's the one thing that has changed.
Exactly.
And yet you go back and think, actually, this medicine that I didn't think was very helpful must have been doing something. It's at the end of the day, it wasn't enough, but that's where it becomes really tricky, like looking at what are we coming off of? What was that supposed to help? What are we starting? What are the known side effects for that?
And in that situation, what we ended up doing was adjusting the dose of the stimulant, which was now on board. So we had gone from trying to use atomoxetine to address both the anxiety and the ADHD to now using two more efficacious medications, the stimulant and the SSRI, to address the anxiety and ADHD.
Yeah. I like the idea of trying to use one medication. I think this is why atomoxetine was initially very popular when it first came to market, because of the theoretical opportunity to kill two birds with one stone, or hit anxiety and ADHD.
Absolutely.
But as you point out, atomoxetine is often not as effective as stimulants for ADHD. And certainly, atomoxetine is less effective than SSRIs for anxiety, which means you end up using two different meds for ADHD and anxiety. All right, listeners, we've covered a lot so far, so I want to hit the pause button and also share the main things we discussed to help you remember 3 ways to switch SSRIs. One way is to taper down the first SSRI, wait till it's out of your system, and then start the second SSRI. This is the slowest option that has the most time without adequate SSRI coverage. The second way is the direct stop-start, which is best for patients with side effects from the original SSRI and is more rapid than that first way of tapering down entirely. But the drawback is that you lose antidepressant coverage during the transition while you wait for your new medicine to reach steady state. And Dr. Strawn introduced us to the fancy third way, which he calls the cross-titration, where you keep the original SSRI on while you start the second medication. And this is best for patients who have not had side effects to the original medication, and where you want to ensure ongoing medication coverage for underlying anxiety or depression. The things to watch out for here are potential serotonergic side effects, which include nausea, vomiting, diarrhea, flushing, and restlessness. My big learning point from this episode was that just because we needed or tried a high-dose SSRI for our first trial and didn't have a response, it does not necessarily mean that the patient is going to need a high dose of the second medication that you try. And knowing this, we should start low on the second trial to minimize new side effects on the new med, and then increase weekly to achieve a target dose by around week 2 or 3. So the great news is that we are not done this conversation. We're going to continue next episode to talk through some more complicated cases with Dr. Strawn about switching medications for kids and teens with anxiety. Thanks for listening, and we'll see you next week.